In the last year, for which figures are available, 71 million people were admitted to hospitals in the United States. 71 million. Most of them were cured, fixed, or patched up. Then they checked out rather routinely. On the other hand,
my brother was in a lot of pain, and they take forever to get the medicine to him, and it was in ICU, so I don't have a good taste with hospitals.
They're not as good as people think they are.
As Richard Pryor used to say, people die in hospitals.
I'm grateful that we have them. I've needed one on a couple of occasions.
Money. Big money.
Pretty bad. You know, we have to wait a lot.
The medical field, it seems like it's too money-driven, and it's not really care-driven.
I would never go. I care too much about myself to go to the hospital.
too many American hospitals are sick. I'm Lloyd Dobbins. Hospitals cause death, error, waste, expense. They cause misery and dissatisfaction for their patients and employees. You probably already knew that. But what you don't know is all of that can be fixed. It won't be easy and it won't be quick, but all the things wrong with hospitals can be fixed. If we do fix hospitals, their cost will go down, not up, which makes this that rarest of television programs, a good news documentary.
Well, I went down to the St. James Infirmary just to see my baby there.
The Hippocratic Oath is taken by graduating seniors at the University of Virginia School of Medicine each year. It says, in part, I affirm by all that I hold most sacred
that I will be loyal to the profession of medicine and just and generous to its members. I will use that regimen which, according to my ability and judgment, will be for the welfare of the sick and the well, and I will refrain from that which will be baneful and injurious, and nurture the welfare.
The oath, in its entirety, says that you, as a doctor, will do your best, act ethically, and keep your patients' confidences. The graduates leave with this benediction.
Doctors, go and heal the sick.
If only it were that simple.
Americans are accustomed to getting everyday miracles out of the healthcare system, keep us alive and well past what our parents could have ever imagined, or our grandparents ever imagined. But the system that delivers those miracles is also rife with waste and inefficiency to an extent that I think very few Americans appreciate. 100,000 people perhaps dying each year of in-hospital infections that could have been prevented. 100,000 medication errors in hospitals each year that kill people.
If you have people that are sitting in an emergency room waiting for emergency care for 5, 6, 7, 8 hours, sometimes 12 hours, that's a sign of a sick hospital.
You come in and register in a hospital, you wait. You wait in a doctor's office, physicians are late, you wait for services.
When they do finally get treatment, the fact that they are not satisfied with the treatment, either because of the way that they've been treated, without dignity, without respect, in a hurry.
If you're an internist and you have a patient admitted with a myocardial infarction, the hospital gets paid a fixed payment, whether you stay 1 day, 2 days, 5 days. But if you're the physician, you get paid daily. So your incentive is to keep the patient longer. The hospital's incentive is to get the patient out. And it's just the beginning of the first conflicts between the doctor's needs and the hospital's needs.
I really believe the patient's been kind of forgotten about in some respects, even though it doesn't seem like that makes a lot of sense.
It's not unrealistic at all to consider 40 and 50% waste in the healthcare system.
What's so odd is that you can go into a video store and they can give you every video that you've rented for the last 9 years and every transaction. But you go and register at a hospital, and many times, most hospitals don't know that you were there yesterday. You have to re-give all the same information.
I think what has happened is the care system is so badly broken, it makes it very hard for people to do the right thing.
In hospitals in the United States, 1 in 14 people who go into a hospital get an infection they didn't bring with them.
What Paul O'Neill is talking about is a nosocomial infection. That is not an everyday word. It is taken from the ancient Greek nosokomia, which meant taking care of the sick. It still means taking care of the sick, but in quite a different way. A nosocomial infection is one you did not have when you checked into the hospital. The hospital gave it to you. About 2 million patients are given nosocomial infections each year. On average, one of those patients will die every 6 minutes. So 10 more patients will die of hospital infections while you watch this program. That doesn't have to be. We're going to show you 2 hospital groups that are improving, that are healing themselves. One is in Pittsburgh, the other is headquartered in St. Louis. Their treatment does not involve insurance and does not involve the government. It does involve recognition that hospitals are more complex than they used to be.
Complexity has increased both in technology, medications available, treatments, payment mechanisms.
The most complex production system, delivery of service system that exists in the world.
I think the crisis in American healthcare is the failure to see how the parts connect to the final solution.
And we've made a lot of decisions away from the front line of the patient.
What you have before were simple questions and simple answers.
I think that one of the greatest things that have changed in medicine practice is how sick people have become and how complex the treatments that they need are requiring to be performed by nurses and other allied health professionals.
Heart transplant patients, so other organ transplant patients, and these folks ultimately get into trouble that I never saw when I was a medical student.
Before 1780, surgery involved only 3 people: the patient, the surgeon, and a big guy to hold the patient down. Ether was in the future. By 1920, even for the most complex operations, no more than 30 people would be involved. Now there can be 300 people involved, some of whom have no medical background. They are technicians for the highly advanced medical devices that are now common.
We have 50, 60, 70 years of tradition, history, experience, practice that we have to overcome. We have built up a bureaucracy in healthcare that is truly focused on the bureaucracy. We are doing things for the benefit of ourselves.
Healthcare has become big business, and it's become difficult business.
We may be keeping people alive too long in some situations, and technology, I think, has done that.
There's a 17-year lag time between when a piece of medical knowledge about what would be best practice for a medical problem would enter the academic literature, say a journal of medicine, to the time when it becomes generally accepted as medical practice.
You know, it used to be you'd come into one department, you'd have one test, we'd figure out what was wrong with you, and we'd send you home. Pretty simple process. Now you come into the hospital and you might need to visit 25 departments to have 30 different diagnostic tests that all need to be integrated and coordinated, and multiple specialists are involved in making the decisions about your treatment plans, and the systems are still somewhat geared to the past.
But in the past, as recently as 20 years ago, many of today's patients would have died. Hospitals can do more medically and technically now, but they seem to have lost sight of why they do more. They have lost sight of the patient.
Patients are more complex. Length of stays are shorter. So we have a sicker patient and less time to take care of them.
It's very clear when you sit at the patient bedside that the patient is not the customer, that the enterprise isn't organized around the patient.
The patient probably got lost somewhere in the process of large hospitals, of managed care, and the focus on insurance and benefits.
The nurses and the doctors and the policies and the procedures are set up to make their workflow easier.
The earliest Western hospitals were Greek temples. The gods cured you or they didn't. In Europe and the United States, the earliest hospitals were to hold, not necessarily to cure the sick. They weren't Greek temples, but you lived or died pretty much on your own. Anyone with money was treated at home. During the second half of the 19th century, that changed because of 5 developments. Ether was used as an anesthetic for the first time in Boston in 1846, and that made surgery much more possible. Based on the work of Florence Nightingale in the Crimean War, hospitals began to insist on higher standards of sanitation and hygiene in the late 1850s. Then Joseph Lister used antiseptic in 1865 to prevent infection after surgery. Schools of nursing were established by hospitals in the 1870s to teach proper patient care. Finally, hospitals began to build private rooms for patients who paid, keeping them out of the large wards of the poor. By the end of the 1800s, American hospitals had become the heart of health care, and now they are the organized centers of community well-being. But they cost too much, and healthcare costs are going up at an impossible rate that we will not be able to pay.
An average wage in Pennsylvania is about $30,000 a year. You apply a 3% inflator to that, and a 20 to 25% inflator to health insurance costs. By 2008 or so, it will cost as much to purchase health insurance coverage for an employee as it will to pay the employee, and that's not going to happen.
It's possible for our society to reduce the cost of health and medical care by 50% and simultaneously improve the outcomes for individual human beings.
40% waste in the system. And it is wasted time, it is wasted energy, it wastes people's creativity.
It may be as much as 50%, the amount of times that we do things and then redo them.
We'll work around this problem, work around this person who isn't doing his or her job correctly. We'll work around everything. And you do that 100 times on a hospital floor over a span of a decade, and pretty soon no one can remember why they're doing anything the way they do it.
At 10, if he was maintaining oxygenation well, and then drop off his FiO2.
Physicians aren't typically trained in systems management, and so when there's a problem that occurs, instead of fixing the root cause of the problem, we add one more layer of things to do.
The Pittsburgh Regional Healthcare Initiative, PRHI, includes more than 40 hospitals and some insurance companies and businesses, all of which want to keep medical costs down. PRHI sponsored a health fair to make people aware of the cost of chronic diseases, and one of the speakers was Nicole Johnson, a former Miss America who has diabetes.
Of these conditions. In the past 5 years, southwestern Pennsylvania has seen a 75% increase in hospitalizations due to diabetes complications. That's unacceptable, folks. That can't happen. People are going blind, they're having heart attacks, they're having strokes, they're having limbs amputated, all things that we can prevent with proper care.
The purchasers is paying for the wrong thing. We are paying for the amputation, we are paying for the people ending up in the dialysis chair, but we are questioning whether to pay for prevention.
So far, we have been talking about problems. We begin now to talk about improvements. The key to all improvement is to focus on the patient.
Now,
Paul O'Neill is the former CEO of the Pittsburgh Regional Healthcare Initiative. He is former Treasury Secretary and former CEO of Alcoa, which he turned into the safest company in the world to work for. He wanted to use the same techniques to heal hospitals.
we don't have to take what we have as a given and accept medication errors and infections acquired in a hospital that you didn't bring with you, and the incorrect procedures that stem from a lack of knowledge or training.
If you eliminate errors and infections, you do two things immediately. First, and obviously, you save lives. Second, you save a ton of money. Nosocomial infections alone add about $7 billion annually to healthcare cost. That is twice as much as all the medical malpractice awards in the country. Healing our hospitals won't cost nearly that much. One technique that PRHI used, which was all but free, was simply sharing information among its hospitals.
Had I not gotten engaged in PRHI, not only would I not be here, but I might not actually be doing what I'm doing today, which is taking better care of my patients, feeling better about the work I do, engaging with my colleagues in a collaborative effort that is exclusively focused on what the patient needs.
We learn from one another so that we don't have to go through the same kind of lessons that we were doing this just by ourselves. The information sharing part of the PRHI, to me, is the most exciting part.
This is a story about sharing information. The Pittsburgh Regional Healthcare Initiative, PRHI, adapted the idea from New England hospitals. An individual cardiac surgeon may see 200 patients a year. The hospitals together will see 6,000. You get much more information in the same amount of time, so you can make more improvements faster.
The average mortality in southwestern Pennsylvania from a cardiac surgical bypass procedure is about 2.3%. We can reduce that another 25% by doing 4 things. The uniform use of an aspirin prior to surgery, that costs about 3 cents. The uniform use of beta-adrenergic blocking agents, which costs about 50 cents. Use of the internal mammary artery as a bypass graft, which costs nothing. Measurement of the blood hematocrit during the bypass operation. Individually, we would have never come across that data ourselves. We recently discovered that, in fact, our mortality is declining and that our use of these interventions is increasing.
We wouldn't be doing this in attempting to change our behavior and the behavior of other surgeons in our institutions if we didn't have the data that support it.
You need long-term research to pinpoint long-term problems. You need real-time data to solve immediate problems. You replace each doctor's experience with every doctor's experience. For instance, how often did open-heart patients wind up right back in the hospital? Most doctors guessed 5 or 6%. Try 17%.
That really suggested to us that there's something in the process of care during the last days prior to discharge that must be fixed. We found that many patients who leave following the stress of surgery go home and take the medicines they were taking before their operation as opposed to the one that are prescribed afterward. Many patients don't know how to clean their wounds because the wound is cleaned for them in the hospital. But teaching them these very simple measures, creating a standard discharge format, which makes sure that there's a checklist that we go through, that every patient has the information, affords us the opportunity to create what we call the perfect discharge.
If you can create the perfect patient discharge in Pittsburgh, might you also create the perfect patient admission in an emergency room in St. Louis? SSM Healthcare, sponsored by the Franciscan Sisters of Mary, runs 20 hospitals in 4 states and wanted its emergency rooms to be better.
Most communities have a love-hate relationship with their local emergency department. They either love them to death because something tragic happened and we saved their loved one, or their experience has only been ugly and they've had to wait too long and nobody talked and the nurse was rude and, on and on.
And we found a hospital in Detroit, quite frankly, that had a program that they referred to as their 30-30 program. The sense is in 30 seconds they will make certain that anyone that comes to the hospital with life or limb-threatening chest pain, whatever that, they will be seen immediately. But for all others, they would be under active care within 30 minutes. So we wanted to replicate that program.
There wasn't anything the emergency room could do of themselves. It turned out to be an entire hospital activity. That's the greatest example that I can think of for systems thinking.
Sister Mary Jean Ryan heads SSM and uses systems thinking to make improvements. We'll get to it later, but remember the words systems thinking.
If you try and do it just in the emergency department, it'll fail. You have to have the support of housekeeping to get the room clean so you can get the patient out of the bed here and admitted to the hospital. You have to have the commitment of administration. It has to be a whole institution-wide initiative.
This was going to require a systemic change of our whole organization and a totally different culture.
We said, we're too busy. We got too many ambulances, we have too many, there's no way we can do this.
Took us at least a year to organize the hospital, get all of our employees committed to that was part of their job, even though they didn't work in the emergency service department.
It became a total culture change for this facility. It became a primary initiative for everybody.
Every department identified what their role was going to be in the initiative, what they would do to help support it.
We actually took a time card. The patient clocks in when they're triaged, there's a time for that. When they're placed in a room, there's a time for that. When the physician sees them, there's a time for that. And we would realize initially, well, we have a long time between when the patient signs in and their triage, so we need to streamline that area.
It's like a fine-tuned machine. You need to make sure in an engine that all the different parts are working together in order to help that car, that engine run smoothly. And this is very similar.
One way to help the hospital run smoothly is to establish protocols. That is, standard treatments that nurses can start immediately or that doctors can use as a checklist. The protocols are based on research and experience.
Chest pain, strokes, seizures, abdominal pain, extremity pain. Most of the visits that you see in the emergency room, we try to come up with a protocol where we can at least start their care. It's a little tight because your blood pressure is kind of high. Say, for instance, you come in and you have chest pain. We all know that a person with chest pain, they can't sit for a long time. So what I could do as a nurse, I could pull that chest pain protocol. I could get an EKG done and get it shown to the physician immediately. I could go ahead and put the patient on some oxygen, put them on a cardiac monitor, start an IV, draw some labs, and then start my medicine. That patient would have decreased anxiety, decreased pain, and hopefully no damage to the heart. And that's the goal that we're looking for. It's going down now. As you feel it now, it's getting a little looser and looser, so it'll go down in a few minutes.
Sometimes, to help the hospital run more smoothly, you have to rearrange the parts. If you put X-ray next to the emergency room, could doctors get their X-rays faster?
We're looking at a 30 to 45-minute turnaround time, and we've minimized that to about 15 minutes. The films are shot right here next to the emergency room. They're developed and they're put up for observation by the emergency room physician.
Some improvements have nothing to do with medicine, but they make patients feel better, and they free medical people to do medical things. The emergency room now has a hospitality person.
And is there any questions you might have? Or?
When can I see him?
And their whole job is to just go around and talk to people and keep people informed on why you're waiting, what's going on.
The hospitality folks can come in and say, you know, Mrs. Smith, how are you feeling? I know you got something for pain a little while ago. Are you feeling okay?
I just want to explain a few things to you.
People just love that person. They're not clinical at all. You know, they just fluff and buff everybody.
We will come get you in a few minutes, and you can go back there and stay with him. Okay?
Good.
The key to all improvement is to focus on the patient, and the patient was the reason to reorganize the emergency room. That reorganization required every department of the hospital. It required an awareness of the hospital system, and it required a specific, agreed goal.
And when we started the program, about 30% of the patients that would come to us, they would be seen within 30 seconds or under active care within 30 minutes.
And now we've been exceeding 90% for 2 years.
It gave us a great sense of pride in doing something that we believed in the beginning was not possible, and we achieved it.
Paul O'Neill ran the Hospital Improvement Program in Pittsburgh, Sister Mary Jean Ryan in St. Louis. He is a businessman, she is a nun. It is difficult to think of two people who come from more different backgrounds, yet they both reached exactly the same realization. Each hospital is a system, not a collection of unrelated departments. To heal each hospital would require three things. First, leadership.
Then I think it's the role of the leader to establish goals that everyone can relate to.
Second, you would have to have a goal of perfect patient care. And third, you would need systems thinking.
And I think what systems thinking says is that you can't do one thing in isolation without knowing that it's going to impact all other things.
I said we would get back to systems thinking, and here we are. Systems thinking can be complex, but in this instance, it is not. It is basically how you see things. Instead of seeing one huge mess with one problem piled on top of another, you see differently. You see with what people call new eyes. You see how you and your work fit into the system and how you and your work connect to the other people in the system.
In a complex environment like healthcare, everybody doing their very best obviously is not good enough. We have to have a systems approach to be able to tie all this together.
I'm going to give you the educational things that you need to identify things that we can work on and what are some ways that we can work. And what I will also then do is give you the freedom to make the changes you need to make. And guess what? If you make a mistake while we're doing this, it's not going to be your fault. It's the fault of the process.
All systems consist of processes, and that is true in manufacturing, in a school, or in a hospital. The idea of every process is to reduce waste and serve the customer. The only way to do that is with information, data. Nothing is done by intuition or habit or accident. To understand a process, to improve it, you have to understand how the people in the process relate to each other.
Healthcare is a team function. It requires exquisite teamwork among a group of, frankly, equally important players performing different roles. Respiratory therapists, perfusionists, your nurse's aide, everyone has to play their role precisely for the care to be as good as it could be and the patient to recover quickly.
But if you only know one piece of it, you're never going to be able to fix a process. Processes in hospitals are so broken that there really isn't any way for people whose good intentions are clear, they can't impact it positively without really going through the stages of process improvement.
We can eliminate the waste and we can give better care to the patient by making it a better process.
Lest you be confused by words, a process is nothing more than a number of people working together toward a specific goal. A system is all of those processes combined. Think of it this way. It's not quite true, but it's close enough. In a movie, each scene is a process. Put them all together and you have a system, a film.
We are really now beginning to understand that we have archaic processes in our hospitals that, for the most part, set up our clinicians in an atmosphere that allows them to make errors. It's because the processes that we have either stress our nurses, don't allow physician interactions correctly, but the problems that we have are not mostly the individual, and it's more the system.
To solve the problems in the system, you have to see the system as you have never seen it before. It is crucial that you see it with new eyes. You have to see the processes working together. You have to see the whole hospital system. You have to see how blaming people does not help. You have to see how to practice continual improvement, and you can learn how to see all of that.
Seeing things differently, seeing through new eyes. I worked here many years, and walking down the hallway, I see things today that I didn't see 5, 10, 14 years ago. And I think it's because I'm looking at things differently.
That one skill all in itself will change the way you think about your work.
Nurses didn't recognize their problem because they dealt with it every day. And it turned out that what they had to do, the heroic effort to actually get through their day, they considered that the work of healthcare.
For example, if a nurse goes to get a medication for a patient and the medication isn't there, but she knows Mr. Smith in the next bed has that medication, she'll take it from Mr. Smith, give it to Mr. Jones, and then she'll go call the pharmacy and replace Mr. Smith's medication. We'll call that a workaround.
The fellow who brings up the supplies, he has to get 5 separate keys to put away dressings. That stuff doesn't make any sense, but I just assumed that was very normal.
Again, what we're talking about is the concept of new eyes. You have to see the errors before you can eliminate them. You have to accept that they are, in fact, errors. Business as usual has no place in systems thinking.
Case pharmacist had about 150 prescriptions that he received during the day, and all but 2 of them needed follow-up before he could fill them.
PhD pharmacists who man phone lines to intervene with the physicians. This is a significant waste of time.
In common practice, the pharmacist doesn't see that as an error. He sees it as work.
All right. That's
Those pharmacists could be interacting with patients, doing evaluations and histories, doing education, doing those kinds of things that enhance patient safety.
Most people would say the error occurs when the patient gets the wrong medication.
So many of the things that happen in a hospital that are absolutely pitfalls for medication errors, real medication errors to occur, we just work around them because we've gotten very good at it.
In systems thinking, when a pharmacist has to go back to find out what the intended communication was, that's an error.
Errors occur everywhere unnoticed until someone with new eyes notices them. An error could be as simple as a lock and key.
We followed nurses minute by minute, shift by shift for several days, and we found a nurse was wasting time looking for a key. And so today, each nurse, when they come on the shift, they get their own set of keys. So there's no waste. There's no one running around looking for a key. But most importantly, the patient's getting what they need right away.
The improvement focuses on the patient, and in this case, the patient is helped, but so is the hospital. The key is saved 15 minutes each shift, 3 shifts a day. Over a year, the hospital saves 11 days of nurse time on one ward because of one observation.
Waste is everywhere, and it's a trained eye that is developed over time.
A trained eye or a new eye both see things that make you wonder why. A new doctor wondered why patients were sitting around, half naked, waiting for a bed.
In a kind of a flimsy gown, and it wasn't very dignified. They would get angry, they were frustrated, they were half naked. It was really a bad scenario.
For as long as anyone could remember, patients undressed, put on the little gowns, and sat in chairs waiting for a bed. Why? Because it was easier for the staff.
Okay, so
The process was redesigned by the staff to make it easier for the patients. Redesigning the process eliminates any potential backsliding, which nothing else will do.
So now the patients following registration stay with their family in the waiting room until their bed is available. It sounds so simple, but for 15 years that place was open, patients sat in chairs every day, and so now they don't.
Get out of your chair, get out to your departments, and watch what's happening, because you will be amazed.
You might even be amazed by what's not happening.
I can remember sitting in this room and having several of my esteemed physician colleagues swear up and down, we all wash our hands. I can't believe anyone would accuse us of such inappropriate behavior. So then we went out and trained the infection control nurses how to do observations on hand washing. And our first report was that 32% of the physicians washed their hands.
Which of course means that 68% of the doctors did not wash their hands. What these hospitals are now learning is that trying your hardest and doing your best do not work. In a complex hospital system, hard work and best efforts have to be replaced with intelligent solutions and systems-wide cooperation. That's part of what American experts taught to Japanese industries to save a bankrupt economy after World War II, and it worked.
And mobilizes a team to attack the chronic waste, and in this case, successful.
Using what Toyota Automotive has learned about quality could be the best medicine our hospitals can get.
What do you mean Toyota Productions is going to come to Shadyside Hospital? But when you start tearing apart the principles that they have and how they do get to the root of a problem and find problems and fix it so that it's never broken again, it's amazing.
Toyota is really about
designing work, doing the work, how do we understand work, how do we improve work. So it's not just about cars, it's about how we do our work.
The principles apply generically to the way people together working in an organization produce a product, an information, or service.
From the beginning, quality techniques have been focused on the customer, or in this case, the patient.
What does the nurse need to service that customer, and what's pharmacy as a supplier to that customer? For example, we would send a medication to a nurse in a form as a vial, as ready, thinking it was ready to administer. Little did we know that the nurse didn't use this every time we thought they did in this form. They would draw it up, put it in a mini bag, and hang a drip. I said, well, if you're putting it in a bag anyway, I can do that for you. So we've saved the nurse the time of going and finding a bag, a needle, a syringe, and tubing, and sent it to them in a much more ready-to-administer form. Had we not observed that work firsthand, we would still be sending stuff that they had to play with.
People at the hospital have learned the 5 whys, a Toyota method. When something goes wrong, you ask why, and you keep asking until you get an answer.
A good example of this actually occurred on our medication carts. We found that the batteries were often going dead.
Why were the batteries going dead? Because the battery charger was not getting power. Why? The electrical outlet the charger was plugged into was dead. Why? Because it was next to a sink and it was splashed with water. Why was it splashed? The water pressure was too high, so when the faucet was turned on, the water splashed. So the medical cart problem caused by a dead electrical outlet was solved when the plumber turned the water pressure down. Turning the pressure down means the problem cannot come back, and that's what you want, a permanent solution. You make the problem go away, and when you make a problem go away, you make the blame go away. When you make blame go away, it is safe for everyone to report errors.
People felt better if they had one person to blame. And if you could get rid of that person in some way, shape, or form, then you would be better.
In the past, we have looked at an error as something that we had to blame somebody for. Now we have systems to look at and say, what's wrong with the way we do business that sets people up for medical errors?
We know mistakes and errors are going to occur. We just want to make sure that we learn from those mistakes.
And in order to have learning, you've got to have clear recognition of everything that is a mistake or a waste of resources, and it needs to be explicit, and it needs to be blameless.
If people feel that they will be punished for things that they do or might find, errors will go underground.
When we begin to blame the process as opposed to the person becomes much freer in sharing things that have gone wrong.
There are no bad people, it's bad processes.
The first time an employee comes to you and says, you know what, I hung that heparin wrong, I made a mistake, I think I may have overdosed that patient. Your reaction as an individual is critical. If you say, what in the heck did you do that for? How could you make such a mistake? What is wrong with you? Versus, I'm so thankful that you came forth and told me because we need to do what's right for the patient.
Whether you look at the Challenger disaster, or whether you look at the Enron scandal, or whether you look at the scandals in healthcare that are in the public news every day, they would probably not have occurred had employees working in those industries feel able to say, stop the presses.
Our significant medication error rate was 0.16 per 1,000 dosages administered. Our second quarter this year is 0.01 per 1,000. So we've dramatically improved things, and a lot of that is attributed to, I think, our continuous quality improvement culture.
Because he is talking in fractions of 1%, it's easy to miss how much of an improvement that is. Try it this way. Last week, something you wanted cost $16,000. This week, because of continual improvement, it costs only $1,000. Next week, Again, because of continual quality improvement, what the people in St. Louis call CQI, it will cost even less. But CQI does not apply only to cost.
We look at everything we do and look for opportunities that we could have done it better. Even when there's not an error or a mistake or something bad that happens, we try to take input from everybody and try to do it better each time.
How you learn this is really going, looking and seeing, solving the problems, trying a solution, changing that solution, and if it doesn't work, trying another solution.
What we found was a lot of waste was not considered waste until we understood the process better.
Even though we began this initiative quite a few years ago now, we still meet every 2 weeks to identify what are the barriers to the success, what are the issues we're dealing with now.
Sometimes, with continual improvement, what you do is not new, but it is better.
We in medicine have known for at least 25 years that high blood sugar reduces the ability of the white cell to deal with infection. And so we went through a stepwise process to reduce our blood sugar targets. And in that last 20 months, we've seen our intensive care unit mortality drop from about 5.5% down to about 3.2%. We've reduced the number of acute in-hospital diabetic complications from about 13.5% to about 5%. Clearly, SSM's philosophy of continuous quality improvement makes the implementation of this kind of a program much easier.
Continual quality improvement also makes it easier to do things patients like, answering their call lights quickly.
Okay. Hi, can you help you?
Patient satisfaction that the call light was answered quickly was at about 92% last year, which was good, but we've got it to almost 97% so far this year. We share that with all the nurses in the staff meeting, and that always makes them very proud.
Making them very proud apparently makes them very satisfied. The rate of turnover among nurses at SSM is about 1/3 the national average. SSM was the first healthcare organization to win the Malcolm Baldrige Award for Quality. The Baldrige Award is a federal government private sector partnership to improve quality in manufacturing, service, education, and hospitals, in part by teaching the techniques SSM uses. Baldrige started in 1988. Healthcare was added and SSM won in 2002.
We started to use the Baldrige criteria as a framework for process improvement in 1995, from leadership to planning, to focus on the patients, our information systems, our staff, and our processes, our day-to-day work. How can we do it better? How can we better understand our current performance and where we want to go?
SSM hospitals are not for profit, so any extra money goes to reduce cost, to provide medical services for the poor, or to underwrite community health programs. The front line, in hospital terms, is where doctors and nurses work with patients, and this story is in Pittsburgh.
This is what a central line looks like. This is a triple lumen catheter commonly employed to administer a number of drugs or antibiotics continuously. This is the needle that is actually used to enter the vein.
It looks fierce, but the problem was not the needle, it was the infection. Central line infections were common, and half the patients who got them died. Doctors and nurses developed a standard procedure that could prevent infection. It worked.
See this dressing? It's occlusive, so you don't get bacteria at the site of the wound.
We've nearly eliminated central line infections in 3 months, and we did it by taking every case one at a time, determining what the cause was, and that allows us to immediately change the process so that it won't happen again.
That then means all those people who would have stayed longer in the hospital, which adds unnecessary cost, and which sometimes can lead to death, all of those costs disappear.
If you take each problem one at a time and solve it to root cause, you can actually overcome these very significant infections, as in this case, in 90 days. So PRHI and the Toyota Production System bring us here every day to do this work. They don't lead us to a conference room where 6 months later we analyze the data just to say we've looked at it. So that's the difference between conventional performance improvement in hospitals and real-time performance improvement. A couple of other points to mention is this work is done by nurses. It's not done by physicians. We ask the nurses to prompt the doctors when they think a line should come out. We ask the nurses to ask the doctors each day, do they really need this going forward? There's a pilot co-pilot approach, where the pilot, the physician putting the line in, and the co-pilot, the nurse, are checking off a list of options, and that's the PRHI, Toyota Production System model. The people doing the work know how to fix the work.
What do they need?
We're no longer going to the boardroom, fixing all the problems, bringing them back to the unit and saying, okay, staff, this is what we want you to do. We're now asking the staff to identify the problem and then to come up with a solution for it.
We very much believe in decision-making at the lowest point possible in an organization.
Because who better is there that knows the work that they do than themselves?
Remember that the primary focus on improvement stays on the patients, even in something as seemingly insignificant as gowns and bandages.
We had just taken the dressings off their mid-sternal incision, and sometimes when that happens, you pull a little clot or something happens that the incision will drain a little bit. And that's a normal thing, not a big deal. Well, I would come over to the drawer and open it up to get a dressing and to get a clean gown for this patient, and it's not there. So then I have to leave the room, go to the linen room to get a clean gown. Well, while I'm there, somebody calls me and says, hey, Pam, could you please help me with a boost? So I help them boost up this patient. Well, while I'm boosting, I get a call overhead that says, Pam, another room needs you stat right away. So I go running back there, and I have a patient who's like in excruciating pain, can't wait. While you're doing that, you get called for something else. An hour or so later, you remember, oh man, I went to get that gown and dressing for the patient down the hall. So you go in there. In the meantime, their gown has a lot more blood and drainage on it, and they have things running down them. So they grab napkins or things that they've blown their nose with, and they sort of dab at it a little bit. And we're thinking that maybe that's a possibility, that is adding a contamination that we can avoid.
Maybe avoiding an infection. The nurses adopted the Toyota Inventory Supply System called TPS. Everyone knows what has been used, what has to be replaced, and who will replace it.
The true beauty of the TPS system is how do you make it easier for people to do the work the right way and not really have to leave the point of patient care.
Solve the bandage and gown problem, take on the wheelchair problem. 3 facilities shared 500 wheelchairs, which should have been enough, but there was a perceived shortage. So nurses and nurses' aides hid the chairs in bathrooms and closets to take care of their own patients. In today's complex hospital system, there is no such thing as their own. Everything is part of the system. A study by hospital personnel found that not only were the wheelchairs hard to find, they were dirty when you found them. Personnel began to wash the chairs, then set up wheelchair stations.
We have different areas where wheelchairs are stocked, so if we run out of chairs on the floor, we have a place to go get them in a timely manner.
The wheelchairs came out of the bathrooms and the closets, and we soon both had enough wheelchairs without purchasing a lot more, as well as freed up some space in those bathrooms, but also wheelchairs that are clean, that don't transfer pathogens between users. The wheelchair system really went from being an emblem of how things can't work at the VA to an emblem of how things can work if we all pull together.
To illustrate that people will do the right thing if you make it easy for them, the hospitals put a phone number on the chairs and got back 40 in the first month. Generally, not always, but generally, doctors do not work for the hospitals where they practice. They are independent contractors. It's as if airline pilots did not work for the airlines, but worked for themselves, were paid directly by their passengers, and flew their planes however and wherever they wanted.
The old culture, so to speak, was where people were practicing medicine in some isolation. That is, they would use their anecdotal experience to treat the next patient because that was the best evidence they had to go on.
I had good relationships with my patients, but my ability to really affect their overall outcome was somewhat limited. So like many physicians today, I felt powerless.
Physicians, for example,
do not believe that they will ever be able to get into an environment where they are not constantly hitting their heads against the wall to try to get work done efficiently and without error.
And we can show them the data that these patients then have better outcome. They buy into it because physicians basically want to do what's right for the patient.
Doing what's right for the patient seems more difficult to know than it used to be. We live in a medically and technically complex world that is getting more complex by the day, and one of the hardest lessons to learn is that what used to work doesn't work anymore. To improve, you can't do what you have always done. But as you learn how to improve, you can't help but wonder just how close to perfection you might be able to get.
We will systematically figure out how to eliminate all infections that occur in a hospital.
Define what the ideal is in any situation so that there will not be any medication errors. There will not be any nosocomial infections.
You never actually get to absolute perfection. It's an endless quest.
By actually going to the ideal and then coming up to the barriers that keep us from those ideals, we can clearly define the countermeasures necessary to get us closer and closer to the ideal.
So when you're looking to redesign your system, you don't want to design your system to be 98% good. You want it to be 100% effective.
Making sure people can't do the wrong thing.
We have to put processes in places for the nurses, even under times of stress, so that errors don't occur.
Very good. Yeah. The complexities of taking care of the patients can be so overwhelming. There's so many things going on at the same time. There's so many different demands that it's really beyond the capability of even very bright, well-intentioned people to remember every single detail. And so you have to build it into the systems that reminds them of the detail or alerts them to the possibility of ordering the aspirin and beta blocker.
In the airline industry, they recognize human beings can make mistakes, and they have really intensive checklists that they go through. They build in a human factor, they build in a mechanical factor that makes it much, much more difficult to make an error.
We have over 30 order sets for the common diseases, which brings structure to that treatment plan to try and prevent folks, really very good and talented people, from making simple errors of oversight.
We're trying to make sure that we treat all of our patients with these various conditions according to evidence-based medicine and have it standardized and systematized across the organization.
What has been done in St. Louis and Pittsburgh is working because all of it, as I've said several times, is focused on the patients. It is not focused on reducing staff, reducing cost, or improving profits. But as you focus on the patients, all of those other things occur naturally. You want to help the hospitals? Help the patients.
So it was a huge learning to be able to look for things that robbed me of time from patients.
And I see a lot of wasted steps that we have done for a lot of years.
It's dotting the I's and crossing the T's that saves a great number of lives in the hospital. Most people have common diseases for which we have common and very effective treatments.
Giving aspirin in the emergency room for an acute myocardial infarction, and we were probably 40 to 50% compliant in that. And now we're 95 to 98% compliant.
I would believe that if we eliminated medical errors, there would be no malpractice. I now believe through PRHI, eliminating medical errors is entirely possible. But the work begins with us.
The methods we have shown you are known, tested, and proven. They do not require more staff or expensive consultants. They do not require the health insurance industry or the federal government to do anything. Improvements can be made starting today in every hospital in the country. Costs will come down. So the question now becomes, can we afford not to heal our hospitals? We can, if we want, not do anything. But if we decide not to do anything, we have to accept that every day, 500 people will die in hospitals in the United States who did not have to. You and I might be among them. Costs will come down. About $1.7 million saved with fewer deaths as coronary bypass readmission declines 4.7%. 85% reduction in hospital-acquired infections, infections that are often fatal and cost $30,000 to $90,000 each. A 63% reduction in central line infections since 2001. Half are fatal, and each cost $30,000 or more to treat. Staph infections were reduced from 26 per thousand to 8 per thousand.
To obtain a copy of this program and other instructional material on systems thinking in healthcare, please call 1-800-453-6280 or go to managementwisdom.com.
Well, I went down to the St. James Infirmary just to see my baby there. She was stretched out on a long white table, so sweet, so cold, so fair.